Hello and welcome to this brief overview webinar for you. If you are training, coaching, or consulting with someone who has diastasis recti or under the assumption that on a relatively regular basis, we as coaches and trainers and instructors come in contact with clients that have diastasis recti, and we need to know how to serve that client best. So I will be sharing my screen with you. We can kind of follow along together. If you're here with me live, then you will simply click the chat button to ask a question. And at the end, I will go back and gladly answer your questions. So here we go. Sharing my screen. Coaching and training the client with diastasis recti. So let's just start with the basics. What is diastasis recti? It's a term that has finally recently reached some media and some news, and it's getting some attention. It's actually a very common core injury, and it is the separation of the rectus abdominis, as shown here, down the vertical line somewhere along the linea alba. So as you may know, the rectus abdominis is the long muscle that reaches from the rib cage to the hips, sort of goes into the pockets, and it has ridges that when they are built as muscles, they look like a 6 or 8 pack, but it's actually one long muscle. And that muscle can get overstretched or even tear in the center down that linea alba, which exposes that center part of the abdomen really to just skin and some thin tissue rather than being covered with the complete abdominal wall as you see in the picture on the left. So who gets diastasis recti and what does it look like? You can see my image there on the right of some people that I know, and they have diastasis recti, and from the outside it might look like loose skin, abdominal fat. It might look like someone is pregnant and they are not. It might look like there's a bulge in the center in between the two halves of the rectus abdominis. So who gets diastasis recti? Well, quite often it is women who have been pregnant. And it's very common. In fact, 65% of pregnancies end in some amount of diastasis recti. That's why training the postnatal client is a little different from training other clients, along with several other factors in a postnatal client. But this is one that definitely needs to be addressed well by trainers, coaches, and instructors. Also, people that have just gained a lot of weight around the center of their body can have the same effect. They can have a division down the center just from weight gain around the middle of their body. Also, people that are lifting heavy weights, if they push the abdominals out at a certain point of their weightlifting, it can push it out until it opens and spreads. And that has really come to my attention and other coaches' attention lately as I'm getting an increase in questions from people who have been lifting heavy weights for many years or who perhaps were not trained in good form in their weightlifting. And they're wondering why they feel like their intestines are coming out of the center of their body. Also, excessive vomiting can cause diastasis recti. I've seen this in a couple of people. It's not extremely common, but I have seen people come to me that have had bulimia or a long-term illness that has caused them to vomit. So that can also eventually open the rectus abdominis in certain places. Now, some people are going to know that they have diastasis recti, and it's getting better. I will say when I had diastasis recti in 2005, almost no one talked about it. Almost no one was diagnosed with it, and it was considered a rare disorder. And I think they said the stats then were 15% of postnatal clients. Now they're realizing that it's more like 65%, which is what I had found with my own research before other researchers decided to also start stating that fact that we're finding it in 2 out of 3 women who have ever been pregnant. She might know that she has diastasis recti. She might have checked it herself or had someone check it for her. Or she might use some of these other descriptions, such as belly fat, extra skin, digestive problems, and lower back pain. Again, sometimes you can tell from the outside if she's having these complaints and perhaps the abdomen looks protruding and she is not pregnant, and maybe has a flap over the waistline that looks like it might just be extra skin, when in fact it could be the muscles falling out of the body. So to self-check or to check for the client. Now, me as a certified professional and as someone who specializes in diastasis recti, I offer that service to my clients, and they come to me and ask me to check their injury for them. If you're not a specialist in it and you don't know what you're looking for, you can simply guide your client to go through the self-check themselves. It is on my YouTube and on my website. All she would need to do is lie on her back, hands behind her head, feet flat, knees up, exhale and do a crunch with a rounded upper spine. And then take the hands, go in between the navel, and that's usually the first place to check. Does the hand go through the muscles at the navel? In other words, can you feel a ridge of muscle on either side of the hands when you put the hands into the navel? And then you start to move yourself up the rectus abdominis and then back down the rectus abdominis to see if there are other places of injury. Some injuries are higher, all the way up to the sternum. Some go lower, and some go all the way down to where the TVA would be covering where you can actually check it. So if it's below the navel, you can assume that it's down below the TVA in the lowest part of the abdominal walls. Again, if you're not an expert in this injury, you may just ask her to take a look at the video and try it herself and see if she does have an injury there. If there is a feeling of protrusion in between the muscles, that could be an umbilical or intestinal hernia. And that really should be determined officially by a physician. So I would refer her at that point to see a doctor. A hernia can continue to get worse, or it can just stabilize, and a doctor could help more with that and also get the ultrasound to see where the muscles are and where the protrusion of the hernia is. Now, what do we tell them? She's going to come to your class, or she's going to sign up for a personal training session with you, and she's going to wonder, can you help me? Or can I work out with you? Or can I take this class? So usually she can take the class and she can work with you, but there are just a few things that she's going to need to do that are different or more focused than what you're doing with a client that does not have an injury there. Now just remember, if you have any client that has an injury, they just need accommodations and modifications that may be slightly different from other people. If you have a pitcher coming to your class, he might have a rotator cuff issue. You're going to adjust the movements that he does for his shoulder because of a rotator cuff issue. If you have a linebacker coming to your class, there's a good possibility that he has a hip or knee issue, or maybe lower back. So you give accommodations, modifications, and adjustments to that client so that he can work out with you, so that he can get in a good workout. It doesn't necessarily have to look exactly like everybody else's. Let's talk for a minute about this issue of core engagement. And this is something that I talk about over and over and over again, because we throw the word around in this industry as if everybody understands what that means. And here's the truth. There are people that naturally core engage, and there are people that don't. There are people that walk around with their navel lifted up and their TVA pulled in, and there are people that just let everything fall out. So it's our responsibility as trainers and coaches and people who probably automatically engage our core, we're just made that way or have trained ourselves that way. It's our responsibility to do our best to explain to someone with a core injury how to best engage their core. So start with lining them up and checking their posture. Usually when you take a client that has diastasis recti and you look at them from the side, you're going to either see the chin forward or the shoulder rolled forward, or the shoulders pulled so far back that the ribs splay out, or a dip in the lower back with the butt sticking out, or the hips tucked all the way underneath to where the alignment is off in the other direction. So checking the ear over the shoulder, over the hip, over the knee is a good way to start, and helping them see and feel the slightest adjustment for their best personal posture, and then how to use their best personal posture when they're working out with you. The second thing that you would want to go over is breathing. Now, different people and different strokes for different folks. I am a student of Pilates, and I truly and honestly believe that my studies with Pilates is the reason that my clients and students are progressing faster than people who are just breathing into the belly or breathing any abstract way. Teaching someone Pilates breath is important because that helps with posture and core engagement. If you don't know how to breathe the Pilates way, I have several videos on my website, and there are lots of Pilates specialists. If you've never taken a Pilates class before, I would say it's a really valuable thing to have in your repertoire, just to understand how the breath into the lungs can impact the entire body. And then when we teach our client how to core engage, we teach them, first of all, that nice alignment, pushing the tailbone down just enough to lengthen the base of the spine, pushing the top of the head up just enough to lengthen the back of the neck and the top of the head. So what they're going to do is they're going to push their forehead up. Your crown is over your ear, pressing that section up, and then pretending that there is a hammock on the front of your abdominal wall between your navel and your pubic bone. And that hammock is just holding up and in, not squeezing, not vacuuming, not doing anything crazy, but holding everything in. And then on the other side, under your ribs, where the top of your rectus abdominis lies, should not be splayed open, but should be held so that the ribs and your pelvis are in line and in balance with each other. It takes a lot of practice for a non-core engager to core engage, and suddenly the light will turn on and they'll go, oh, that's what it's supposed to feel like. If you were naturally a non-core engager, you've had that experience probably. If you are a natural core engager, you may have trouble with that communication process. Go through some of those little pointers, making the spine longer and the zipped up too tight from the pubic to the navel will really help them draw everything up and in. Now, I was not a natural core engager myself, and the study of Pilates, again, is what really helped me figure out that that was going to lead to healing in all parts of my body. So I can't emphasize enough knowing that one skill for your daily life and for your exercise. Okay, so they're coming to class, they're encouraged by you, and they believe that they can get in some level of fitness. So what can you do as their trainer, coach, or instructor to modify exercises so that it is safe? Because here's what I'm telling you, coach and trainer, it is your responsibility to keep your clients and the people in your class safe. And if we ignore that, especially if they have asked and talked about it, then you're making yourself and your facility liable. People are getting more educated on all of this. I get tons of emails every day with questions. There's a lot more keyword searching traffic happening right now because the knowledge is finally getting out there. Unfortunately, a lot of what is going out there is incorrect as well. But at least the terminology is getting out there. They're going to have questions for you, and you need to have some structure and balance in what you're teaching in order to teach this person safely and to release yourself from liability. So first of all planks should have at least one knee down, every kind of plank. And your client is not going to understand the difference between the planks, whether it is a regular all fours plank, whether it is a side plank, whether it is a plank that happens during a burpee. They're not going to understand that those are all actually from the same base of planking, and they need to put at least one knee down. Why is that? Well, because when you're stretching from all the way at the head to all the way at the foot, and the lower back tends to have some issues with this injury, and gravity is pulling down on the center of the body, then all of that is going to seep down. It's going to reopen the injury and possibly pull some tissue through that abdominal injury. With the slight adjustment of just setting one knee down, it relieves that pressure, and all they really have to worry about is that pelvic tilt and keeping the core engaged from here, supporting themselves with the rest of their body. The second modification is that this client should not do crunches or sit-ups at any time other than when they're taking their initial test, and they can test once a month at the most. Otherwise, when they're lying on their back, they should not lift their head. And all that means for you as the instructor is to have a simple alternate exercise if you are going into crunches or sit-ups. They also should not lift 2 feet at a time off of the floor. Or if you're training someone in the Roman chair, they should not lift both legs out. That pushes the abdominal walls outward from the injury every single time. It would be extremely painful for a client with a bad injury, and if it's not already bad, it could become bad very quickly. It just reopens the injury. Very simple solution is 1 leg at a time instead of 2 from that position. And then the third, and one that I think a lot of people miss, is pulling from above the head down. So you're either on a pull-up or a lat pull down, or mimicking that behavior, because that is an issue for the top area of the core. Every time you do a pull-up or a pull down, it can splay the ribs open and cause more injury at the top of the rectus abdominis, and it takes the person out of that alignment that they need to work very hard on. There are many other things that we can do for lats and for shoulders. So while they're working on this injury, give them, please, an alternate plan. Those 4 things are really the basic modifications to ask someone to do if they're coming to class or if they are training with you. And all it takes is just a little bit of prep work or a quick thought to help that person find something that works better for them. Keep in mind that going through this webinar, learning general modifications, and helping someone with general core engagement is not the same thing as being a specialist in this injury. So give them the general modifications and give them the guidance that they need, but also I highly recommend that the person goes through a therapy process to actually heal the injury while getting fit and getting strong. I have a website all around this topic. There's a lot of free information there. There is also a link to my 6-week therapy system there. You as an instructor, coach, trainer might want to check that out, especially if you are working with the postnatal population, understanding that 2 out of 3 of people in your class are going to have an issue with this. And just to pass that along to your client to say, hey, here's something that I think that you should look at, and maybe it can give you some guidance in the right direction. Let's see if I can go off of, there we go, stop share. And I am going to stop the recording now to keep this a nice, clean recording for us. Thank you for joining me on this webinar to learn about coaching and training the client with diastasis recti. My email address is carrie@carriefit.com, and my website is carriefit.com, where you'll find lots of information on this injury. I am glad to help you and your client as you move forward and learn more about all that has to do with diastasis recti. Thank you.